Hi, I'm Dr. Padmaja Lokireddy. I'm a Haemato Oncology and Bone Marrow Transplant Consultant at Apollo Cancer Center, Jubilee Hills, Hyderabad. Today, we're going to look at some of the common concerns and questions what we have in lymphoma. What is lymphoma and its causes? What is lymphoma? It is a type of lymphatic cancer. And what does lymphoma is due to? Many times we have, every cancer has got some smoking, alcohol, multiple things, but in blood related cancers we do not have those risk factors. Many a times these are acquired mutations. They happen by chance, maybe because of chronic irritation due to some infections, especially viral infections. The other common things what we know is the chronic exposure to chemicals, pesticides, especially pesticides to be avoided, and people who work in farms should use all the protective equipments to prevent a long-term exposure, as this is a known factor to cause lymphoma. Who is most likely to get lymphoma? Lymphoma can happen in any age group, but majority of the times it happens in older adults. Probably. What are the warning signs of lymphoma? The lymphoma, it is the most important question, to be honest. The warning signs could be ongoing fevers not settling down, or weight loss, or severe itching, or somebody having lumps underneath the neck or armpits or groin, or they're having a big spleen on the scans, or it could be that they have a lot of cough not explained, initially thought of TB, not getting better. These are the patients to look, or most important thing, anemia, low platelets, abnormalities in blood counts. These are the signs you have to suspect lymphoma and do investigations to confirm. What are the main types of lymphoma? The lymphoma can be a B cell lymphoma or a T cell lymphoma, and there is another type called a Hodgkin's and non-Hodgkin's. Those are mostly a B cell lymphomas. There are various subclassifications underneath it, but these are the common ones. B or T is important to delineate the treatment options apart from the Hodgkin's lymphomas. What is the treatment process for lymphoma? The treatment always depends on what type of a lymphoma it is and what is the stage of lymphoma, where all it has spread. The staging can be delineated by doing a PET CT and a bone marrow test, and the treatment before we give, histology will tell you what type of lymphoma it is. Is it a B cell lymphoma? Is it T cell lymphoma? Is it a low grade, high grade Hodgkin's lymphoma? Based on that, we would change the treatment. General principles are that in lymphoma, we don't tend to do a surgery. We don't tend to do radiotherapy. The mainstream of therapy is chemotherapy. If you've got a very large mass in just one area, we give chemotherapy to get rid of it and then may give radiation just for that area. The moment you have got a stage 4 disease, that means it's spread beyond, one has to give only chemotherapy, and the middle of the treatment we repeat another scan to see how the patient is responding to the treatment. Suppose most of the lymphoma treatments are for 6 cycles, that goes on every 3 weeks for a total of 6 blocks. After about 2 to 3 blocks, we do a scan to see how the response is. If there is less than 50% response, it means it's not working. We have to change the treatment. So some lymphomas we expect just with 2 blocks, everything should go away. If it doesn't go away, we take it as a warning sign and may have to increase the treatment and may have to plan something different called a bone marrow transplant. We don't tend to continue the chemotherapies and say that we've got some 50% response, give some more, we got 60%. No, there are a lot of expectations. We have to get an early response. If they don't get a good response, you say that this chemo is not working, we may have to change and we may have to plan for a long term so the disease doesn't come back. So the treatments all depends on how the disease factors are, where all it has spread, whether this patient can tolerate this treatment or not, and how good the response has been. Should we change or should we continue the same? There are different various regimes. For Hodgkin's, we generally give ABVD. For non-Hodgkin's, we give R-CHOP. It's not just knowing the name. It's about the complications with the chemotherapy. How do we manage them? And some patients may have multiple other problems. They may have a heart problem, they may have a liver problem, kidney problems. Some chemotherapies are toxic to certain organs, so we need to modify the types of chemos and the duration what we give. And sometimes the lymphomas are in the brain. Not every chemo crosses the brain. So you need to modify and give it differently, and we may have to plan for a transplant because it has such a high risk of coming back. Many a times, I think it's important to tell, patients come for second opinions, third opinions, they go from pillar to post asking for what treatment to be given. They don't bring the patient, they just come with the reports. So if you are given a non-Hodgkin's lymphoma report, one would say R-CHOP, and they would think every center has said R-CHOP, let's continue. But the most important thing is looking after that patient in a holistic manner, looking at their heart, kidneys, how their response to treatment, how their side effect profile is, and what needs to be changed for the long-term plan. And we need to look after the patient as a whole, looking at all other organs along with the chemotherapy. The latest treatments for lymphoma, lymphoma has got chemoimmunotherapy, that is rituximab is an antibody therapy, and chemotherapy arm is a CHOP or multiple other salvage therapies. So chemoimmunotherapy is the first line of therapy. If they don't respond, they go for a second line of chemotherapy. And if they don't respond even after that, then the next line of therapy is a CAR T cell therapy in lymphomas. Especially patients who have got a CD19 antibody positive in lymphomas, they can go for a chimeric receptor antigen T cell therapy. It is a cutting edge, a new technology. Currently, it is not available off the shelf in India. It is relatively a new treatment. It is very expensive, but I'm sure within a short while it will come to us as a standard of care. CAR T cell therapy has got a very good responses, and this could be used as a bridge to transplant or to avoid transplant, especially in elderly patients. You can use this. What type of lymphoma is not curable? So the lymphoma which is not curable is a relapse refractory, that is not responding to chemotherapy and it is rapidly progressing. Those are the times where we give up and say there's no more treatment. But it happens very, very rarely. So if it doesn't, the first line doesn't work, you have a salvage therapies, you have a bone marrow transplant, you have CAR T cell therapy, we have immunotherapies, we have small molecule therapy, we have PD-L1 blockers. So there are different ways you can treat patients, but some patients, that fraction is less than 5% where the cancers are not responding to treatments. They're called relapse refractory, and we may have to say enough is enough. That situation do come. Or sometimes you have treatments but the patients cannot tolerate that, their body doesn't cooperate, or there are other systems like heart and lungs and kidneys don't cooperate for delivering that chemotherapy, because giving the chemo is more toxic than not giving it. In those conditions, we may say there is no more treatment available. Those occasions are very rare. Unfortunately, they do happen in real life. In conclusion, lymphoma is curable disease most of the time. Low-grade lymphomas are treatable. Majority of them get a long-term survival. We say somebody who is living for 5 years, they're almost cured of the disease, and they can go into a general pool, marry themselves and get on to their education, achieve high levels. They would be completely as normal as possible. So it's important, early diagnosis, don't rush for alternative therapies, complete your treatment and have a good follow-up for a total of 5 years. Later on, after 1 year, the follow-ups could be once in 6 months, but do continue. Early diagnosis, treatment and follow-up. Thank you.